Good time of year, spring. You know, we got the Neuroscience Symposium. But most importantly, it's Masters Week. If anybody knows me, you know I'm an avid golfer, so I'm glued to it this time of year. But any golfers out there? Yeah. If you don't know, then it probably doesn't matter. So, anyways, all right. Let's see. Okay, good. So, yeah, I work here at Christus. I'm an RN. Been here almost 4 years, and so I've had the opportunity to speak to y'all today about subarachnoid hemorrhages and from a nursing perspective. Subarachnoid hemorrhage patients, they take a lot of collaboration between all the different teams, and this is where the nurses and their assessment skills really shine and why it's so important. So let's get into it. I'm going to briefly just define what a subarachnoid hemorrhage is, and my presentation is going to focus on aneurysmal subarachnoid hemorrhages and why that's relevant. We see approximately 15% of subarachnoid hemorrhages, aneurysmal subarachnoid hemorrhages, in the neuro-ICU population. And typically these patients sometimes, or most often, stay on our unit for 21 days. So that's 3 weeks in the ICU. And we really get to establish a relationship with these patients. But, you know, sometimes these patients are on ventilators and sometimes they're doing great and they just want to get home. But we have to educate them because at any time they can vasospasm and get worse. So, all right, what is a subarachnoid hemorrhage? It's a type of stroke caused by bleeding into the subarachnoid space. And that's the area between the brain and the thin tissue covering it, typically resulting from a ruptured aneurysm. This condition is critical as it increases pressure on the brain, leading to severe symptoms and requiring urgent medical attention. So, like any patient, whether they're coming into the ER, arriving into the ER, or on the ICU, we're obviously going to start with an assessment. And we're going to prioritize the ABCs first, airway, breathing, and circulation. Once we have established a baseline and know that they are stable, we're going to move on to performing our baseline neurological exam. We're going to establish a baseline NIH, and we're going to repeat that every 12 hours. And that typically is the start of each of our shifts. We're going to perform a men's exam every hour, and we're going to perform initial exam when the patient arrives from the ER to the ICU with the ER nurse at the bedside. And we can compare our assessments to the ER physician's note and the nurse at that time. And we're going to communicate any deterioration to the ICU provider stat. So all of our neuro-ICU nurses are certified in the NIH assessment. And then when these nurses start out on the unit, we are training them on the men's exams just from day one. And I just want to highlight, keep pressing that. Let's go back. Okay. I just want to highlight that this handoff assessment is really critical, not just with the ER nurse, but also when we're handing off from, did I do something? Oh, okay. I didn't, there we go. Okay, cool. Sweet. Thank you. Sorry about that. There we go. So this handoff assessment is really important because this lets us see if anything has changed from when the patient was in the ER or from when we had the offgoing nurse coming onto the start of your shift. And it kind of lets the nurses, with the men's exams, it's objective, right? So one nurse can see something, and another nurse can see another thing, and that gives us a chance to kind of talk and collaborate and make sure that everybody's on the same page. So one of the major complications of subarachnoid hemorrhages is hydrocephalus. So the way we manage it is to always look for signs of hydrocephalus. And let me go back. What hydrocephalus is an accumulation of fluid in the brain. And then with subarachnoid, that's going to be blood. So we're going to be looking for signs of increased ICP, which will be difficulty arousing the patient and a downward gaze. If these signs are suspected, we're going to request a CT head. If confirmed, if hydrocephalus is confirmed, we'll prepare for neurosurgical intervention for external ventricular drainage device, also known as an EVD. It's the nurse's responsibility to have all the required components as per the surgeon's preference, waiting for him at the bedside. We're going to wear a hat and a mask if you're in the gown or in the room during the procedure. And then post EVD, we always want to, after the EVD is placed and CSF drainage is confirmed, we also want to ask the neurosurgeon, hey, do you want to get a CT head just to confirm placement? So let's cover EVD setup. So sterility is paramount. We want to maintain a sterile environment when handling EVD components. So this is using sterile gloves, a gown, a mask, and a cap during the setup. We want to ensure all necessary equipment is present and functional before starting the procedure, including the EVD kit, drainage bag, and monitoring system. We're going to patient the patient's head and body to ensure proper access and alignment. The head should be stable and in a neutral position. We're going to zero the pressure transducer at the level of the foramen of Monroe, or as directed by protocol to ensure accurate ICP readings. And then after insertion, we're going to secure the catheter adequately to prevent movement and reduce infection risk. And this is typically done by the neurosurgeon with staples. And then we're going to regularly monitor for the insertion site for signs of infection, check system integrity, and assess the patient's neurological status frequently. So we're going to zero and level at the foramen or Monroe, and that's just, is it the laser? Okay, there you go. You can see it right here. I just have the, in the image, you have the red line kind of going to the middle of the ear. And then when we're doing any position changes with the patient, we'll always clamp the EVD, and then we're going to re-zero and unclamp afterwards. And again, we're going to maintain sterility to prevent ventriculitis. So when the patients come in and the aneurysm is confirmed, they often go to interventional radiology where they'll be coiled to secure that aneurysm. We're going to establish an initial blood pressure goal, and that's set by the provider, but we're aiming for a lower systolic blood pressure to minimize rebleeding risk prior to the coiling. We're going to use a titratable infusion, such as nicardipine or labetalol for blood pressure control, rather than oral or PRN medications. And we do this to have a tight control over the blood pressure. We don't want to, give a PRN push, and then if it's not working, we just have that blood pressure climbing and climbing. We want to just keep really in this period before going to coiling. We want to really maintain that blood pressure because we don't want the risk for any more bleeding to develop in the brain. And we want to obviously ensure adequate peripheral access is established. More and more of our nurses are getting trained to use the ultrasound to guide the IVs, and that's really becoming a useful tool. And I'm really encouraging a lot of the nurses to pursue that because, it gives you the independence because not all the nurses have that. And if you're able to do that and get access established right away, that's going to help with outcomes. And we're going to consider the the need for central venous catheters, arterial catheters, or urinary catheters. Okay, so the patient goes to IR, they get the coil, and they come back up. Now we're going to switch our blood pressure goals. So after coiling, the blood pressure goal will be adjusted to a higher target. This is typically going to be 160 to 180 systolic to prevent vasospasms. And obviously, we're going to still prefer a drip to avoid any rapid blood pressure drops. And what a vasospasm is just a spasming of the artery that can cut off circulation distal to the area. And this can cause another stroke, and we don't want that. Going into antiplatelet therapy, we want to confirm if a stent is placed to assist with the coil. So we'll have the aneurysm here, and we'll have a coil, and they'll place a stent below that to help with integrity of the vessel. And we're establish duration for IV antiplatelet drip. If it's ordered, we'll also use dual antiplatelet therapy. So we want to verify if the patient has received a loading dose prior to angiogram and avoid duplicating the same therapy for that day. And then if they had the therapy that day, we'll start the daily dose the next day. So this is the best part for nurses: neurovascular monitoring and vascular complications. So we're going to be performing frequent exams after the angiogram. We'll be performing more frequent neurological exams even more often than hourly for the first few hours. We'll also do site inspection, and we're going to inspect the angiogram site for hematomas, for active sites of bleeding or pseudoaneurysms. We'll also be performing pulse checks and ensure bilateral distal pulses, not just on the side of the puncture. We want to be vigilant for signs of lower extremity complications, such as pain, color changes, temperature, or loss of pulse. And this pain, I've had to take care of a patient where he had persistent behind the knee pain, and we were given pain medication and we could not control it, and he ended up having an occlusion of that artery. So once you have those if that happens to one of your patients, it's stuck in your mind, and you know exactly when it happens. And that's a medical emergency, and we need to consult vascular surgery right away. So all these exams are performed every 15 minutes for 4 occurrences, and then we'll move on to every 30 minutes for 2 occurrences, and then every hour for 4 occurrences. So this is 6 hours of assessing. This seems like a lot, and it seems very and you have other patients and other stuff going on, but this is very critical for the patient's outcome, is catching these complications. And this is why I like taking care of these patients and why I like working in a neuro ICU, because this is where as neuro ICU or nurses, our assessment skills really get to shine. And this is where we become a pivotal part in caring for these patients, because everything is revolves around what we're seeing with these patients. So if we miss something and it keeps going on, it can be worse. So let's get into vasospasms. Vasospasms are focal neurological changes that typically present like a stroke, such as motor and sensory deficits, aphasia, dysarthria, vision changes, and this may suggest a cerebral vasospasm. The way we manage this is by administering fluids such as albumin, crystalloids, or RBCs if the hemoglobin is low. Often we'll get a CT angio of the head and neck, but we also want to consider that it could be falsely negative. Sometimes we use pressors such as milrinone, and we can titrate that up to as high as 0.75 micrograms per kilogram per minute. If no improvement after the initial treatment, we'll consult with neurosurgery, the intensivist, interventional radiology for a digital subtraction angiography, and possible cerebral intra-arterial treatments such as like verapamil, milrinone, or an angioplasty. So like I said, vascular complications are arterial occlusions. If a clot is suspected, we will request, and most often we'll start with a bilateral lower extremity arterial Doppler ultrasound, and then we will move on to CT angio of the abdomen with bilateral runoff. If it is positive, we'll request for an emergent vascular surgery consultation. Now let's move on to fluid and electrolyte management. Serum sodium is the big one. So we'll be monitoring a renal panel every 4 hours. We're going to establish the sodium goal with the provider, and we're going to note for any large drops or increases in sodium level. This goal is typically 145 to 155, but it can change. And we don't want the sodium to rise more than 3, but really we're looking for large drops. Okay, for the nurses out there, do we give our subarachnoid patients water? No, absolutely not. We actually have to work with the dietitian. They really can only drink milk and Powerade. And they don't like this, but you just have to educate the patient. This is moving on to cerebral salt wasting. If continuous sodium drops with increased urine output, we want to consider cerebral salt wasting. We will replace with 3% sodium chloride or 1.5% to maintain the sodium close to the upper limit of normal. We want to maintain a net even, preferably net positive, fluid balance to prevent vasospasms. If required, place a Foley catheter for accurate urine output monitoring. So this is probably one of the most difficult parts, especially if you have a patient that is not on the ventilator and is eating and drinking. You really have to stay on and really accurately measure the intake and also the output, and that can be hard. So sometimes we do need the Foley. All right, some key points to remember. So we want to, again, frequent neurochecks and quick interventions for complications, tight control of blood pressure before and after coiling, early recognition of hydrocephalus and vasospasm is crucial. We're going to monitor the serum sodium and for cerebral salt wasting, and then that fluid balance, we want to maintain a net even or a net positive. So, finished a little early, but in conclusion, managing a patient with aneurysmal subarachnoid hemorrhages in the ICU requires meticulous monitoring of neurological status, blood pressure, fluid balance, serum sodium, and potential complications. By following these steps, we can ensure optimal care and improve outcomes for these critically ill patients. So, does anybody have any questions? Yeah.
Okay. So for management of, I know you keep them in the ICU for the 21 days to monitor vasospasm. So or say you're awake alert patient, do y'all still continue doing the MIND exams every hour or?
We do.
Mm-hmm. Okay, because at what point do you weigh the risk of like ICU delirium and management of that?
Yeah. I've seen in some cases or instances, if the patient's doing really well, I've seen them change it to every 2 hours, but I have not seen any past that. It's really, we've had patients that he was at day 21. He was about to go home, and he spasmed. And they had to take him right back down to IR and inject the verapamil. So you just never know when these spasms are going to happen. And so that's why you just have to continue to be diligent in your men's exams and assessing that. So, okay.
Thanks. Also, Matthew, what about, do you hear me? Just wondering, Matthew, as a neuro nurse and subarachnoid hemorrhage, and something happens, the issues go on. What about, talk with us about the communication, the vitality, the importance of the communication with the care partner, the caregiver, in the midst of all of this chaos.
Yes. Communication is key, especially with the interdisciplinary team. So if you have the changes with a patient, we have to page the neuro ICU doctor. And then we need to page, if they have an EVD, we have to page the neurosurgeon. And then we have, if they want to do interventions, then we have to page the neuro IR doctor. So it's really a delicate balance of, oh, is this just something different? Is this small? The best case scenario is if you think something's different, we have to report it. And, we go down and get a CT head. Best case scenario, it's nothing, and we keep monitoring. But, yeah. Did I answer your question, or?
Here you go.
The care partner.
Oh, are you speaking to the patient's family? Yeah. Oh, I'm
Vital.
sorry. Yeah. Yeah, that's also very important too. And what I like to do, it's personal with nurses, all of the different. I like to give the family members like jobs, That makes them like seem involved in the care, and they really like that. And I said, okay, we need to monitor their fluid balances very closely. Sometimes I might have an emergency, and I can't be in here right at that hour. So this is your job. Anytime they drink, I need you to write that down, what they drink. And then anytime, if they use a urinal, stuff like that, then if they write it down, then it's best for the nurses, it's best for the patient, and it really, I think they like it, because it involves them in the care. And so, yeah.
Yeah, anything to keep them away from looking at the vital signs, right?
Yeah, exactly.
Yeah, it's distracting.
Yeah.
I guess we put out the AHA guidelines for subarachnoid hemorrhage. Just the new ones just came out last fall, so it's worth kind of going back and look at those. I thought that was a good presentation.
Thank you.
Thanks. I'll, maybe to your point, one of the new things for the guidelines this year was looking at the post-care. Right, there wasn't a lot of discussion about post-care on the prior guidelines. So what we brought in was a rehab specialist to actually talk about post-care. So there's a lot of we call knowledge gaps in there, which are good things for us to focus on and learn and research. The one comment you had about you said about the 21-day patient, he went back down, right? So he had already gone down for vasospasm management.
Yeah.
Usually, if they've gotten through the first 14 days then they're not going back down. But you are worried about the patients who are in spasm, and you're watching a little bit closer.
Yeah.
We kind of have this, we in our heads by 10 days, there's this, are we going to fast track them or not? We're thinking about it.
Yeah.
But the ones that have already been done there, they're in for the haul. And that's the most important part for the family. When they hit the door, they're in for 2 weeks given.
Yeah.
Right. That's from, the 21 came from all the nimodipine stuff, which we can debate that for ages, but you are in the hospital for 14 days. Plan on it. Y'all start swapping shifts out, things like that. But I like the fluid idea. That's a nice distraction. So.
Yeah. Yeah. Okay.
No, the online people
I think they're going to insist.
It's for the online people.
Hello, if you're online.
Yeah.
I have a question. So we are a primary stroke center, so we do not keep most of the ruptured aneurysmal. So I'm just interested in the management of the post-coiling. But if you have, I'm assuming you do, have multiple neurosurgeons, how do you as a nurse balance their preferences with EVD? And is that written in an order set? Is that found in their narrative? How does that impact like handoff of care if they're not, obviously the same neurosurgeon can't be there for 21 straight days. So how do you as a nurse balance their preferences for settings, for devices and different setups? Because we have multiple at our facility, and they all like different equipment, different ways, and they're not there 24/7. So
Yeah,
that was
that's a
17
good
questions. I'm
question.
sorry.
Yeah, we typically just use the Becker device here, and we're always, leveling at the ear. That's pretty standard. What we'll see with neurosurgeons' preferences is typically just on, some are more aggressive with getting them out of the patient early, and some like them to be in longer. It really just depends on their ICPs, their drainage, and so on and so forth. But yeah, it can be a battle, and it's hard for the nurses because you have to adapt to what that surgeon, 1 week you might be doing this, and then everything changes the next week with the oncoming neurosurgeon. But you just try to balance it and then meet their preferences the best that you can. So, yeah. Did I answer your question? Okay. Okay, sorry. Yeah.
Sorry. I'm just going to say something about, their preferences and stuff. It's always best to talk to them and follow them whenever they make rounds to your patient and ask them, what do they want the ICP to be? Do you want this open all the time, or the level? Do you want this? And also, on top of that, they usually write it on their notes. Yeah, so you can always find it in their notes. Sorry.
Yeah. And it's always good to, there's not, for some reason in Epic, there's not an order for where would they want the level at, so on and so forth. And it's okay to ask them, hey, what do you want? And can we put a nursing communication order in so that, some nurses are more, confident with doing, performing that, but some nurses really, you should have an order in, to tell you what to do. And they're not always the best about putting their orders in. So it's really good to clarify, so yeah.
Yeah, I don't think, as the neurosurgeon in the room, I don't think order sets, they help, right?
Yeah.
But they don't help with the preferences. That's usually you start off. I would say hire an intensivist, but you have,
That's typically what it's.
Yeah, and so there is a little bit more. We've gone through where it was only us, right, to having a neurointensive program where we communicate with. We round with the intensivist, so everybody's on one page for that reason.
Yeah.
And we're the only team in the hospital that rounds with the intensivist every time, and
Yeah.
that helps get everybody on one page. But it's hard to have multiple different levels of people communicating, and you guys are just running around trying to catch the water drops, right?
Yeah.
So, but it could be better. It's just what we do, right?
Yeah. Well, if is there any more questions? Oh, yeah. Okay.
This is a question from online. It's from Catherine Smith. Is there anything in a phone handoff other than MEND or NIH that I can convey, since MENDs can be objective when transferring the patient to the neuro ICU? She's from Sulphur Springs ER.
Okay. Obviously, we want to establish like blood pressure, and because sometimes they don't know exactly what the blood pressure parameters are, and so we can convey that to them. Also, MENS and NIH exams are great to talk about. Also, just a baseline neuro assessment is good to cover too. Yeah. But no, those are great. The MENS and NIH are great assessments, and they're really thorough. And so, if you're not 100% sure, you can ask them. They can ask us, this is what I'm seeing. What do you think? And then we can go on from there. So we're on the same page.